And will someone be reviewing the chat questions, or you want us to do that as well?
We will be monitoring the chat questions. So if something comes to you, but you can answer if you're not on chat right away, if you're not speaking right away, then feel free to connect there. But then also the last 5 to 10 minutes, we go over the questions and make sure that everyone has a chance to answer. All right, Isaac, do you want to let people in? And we'll get started in just one more minute. We'll get started. Welcome, everyone. There's the dog.
There's the dog. Right on cue.
We promise, well, we may promise no flies, but we can keep the dogs out of the call right now. Great. All right, well, let's get started. Good morning, good evening, good afternoon, everyone. Welcome to the Agents of Impact call number 24, the power of finance, the power of finance, solar financing for frontier clinics. My name is Laura Stachel. I am co-founder and the director of operations of ImpactAlpha, and we thank you for taking the time to be here with us today. Right before we get started, I just want to go over a few of our house rules. Everyone's on mute right now. If you like to make a comment when we open the room for questions, please unmute yourselves. The call will get started with David introducing the panelists today. We'll keep the chat features on for this call, so please feel free to introduce yourselves on there, ask any questions. We'll be monitoring the chat so that we can ask the questions for our panelists today. We are recording the call and it will be available with a write-up early next week. So keep an eye out for that in case you missed something on the call today. At the top of the hour, we will end the recording and we keep the room open for sort of like a happy hour after show party. So if you have time, please stay with us. We always have fun, have lots of great questions, and get all of you to connect. And with that, over to you, David.
Thanks, Zulema. Hi, everybody. I wanted to say welcome, Agents of Impact. As you all know, Agents of Impact can be working on all kinds of different challenges in different sectors, different geographies, different asset classes, different business models, including nonprofit as well as for-profit. And the unifying factor is impact. So one of the joys of these Agents of Impact calls is bringing together folks, across all those boundaries. And that's what we're going to do today. If we were meeting physically, I would ask you to reach, to the row behind you and shake somebody's hand and introduce yourself to somebody you don't know. Of course, we're not meeting physically and you can't shake anybody's hands, but maybe what you can do, and what I would invite you all to do is, and some people are doing it already, is introduce yourself on the chat line on the Zoom call here. And what you might want to do, just to kind of break the ice, is kind of situate yourself a little bit, and then we can break through those boundaries. So let us know whether you, first of all, come from the ImpactAlpha community or from the We Care family, whether you're a finance type or a health type or a solar energy type or some other type. Whether you're an SDG 3 person, an SDG 7 person, maybe an SDG 5, which is gender and women, 13 is climate, 17 is partnerships and cooperation. Let us know what country you're in, anything else you'd like to share. Whether you're an optimist or a pessimist in these strange times. For starters, crossing the boundaries between ImpactAlpha and We Care Solar, both organizations dear to my heart. So I want to welcome Dr. Laura Stachel. Laura, hi.
Hi, David.
So great to be here and so great to be doing this together. As I've said in the brief the other day, I've been working with We Care longer than I've been working with ImpactAlpha. We started ImpactAlpha while I've been involved with We Care on the board for, I think, at least a decade now. And I've learned such a tremendous amount from you. So I want to have you share some of that with folks. But let's introduce the other guests first, just briefly, and then we'll come back. We'll come back to that. So Jem Procaro from Solar Energy for All. Welcome, Jem.
Hi, David. Great to be here.
Great to have you here with Solar Energy for All. Been working on this for a long time as well, including with We Care Solar. Rehan Alahi from the World Bank. Welcome, Rehan.
Hi, Dave. Nice to be here. Thank you.
And if you folks want to say like where you're from, where you're coming from now, just so people can have a little bit of a geography. Phyllis Costanza from UBS Optimus. Welcome, Phyllis.
Thank you very much. And I'm here in New York City. Great to be here.
And Michael Liebrick, I think, is going to join us. He may not be.
No, I'm here.
Ah, good. On deadline. Hi, Michael. How are you?
David, I'm so sorry. The last thing I was on just ran over. I couldn't get off, even though I'd much rather be here doing Impact. I've just said hello in the chat as pale, male, stale, SDG 7er reporting for duty.
There you go. Okay, you're a model. You're modeling the behavior here. So, welcome everybody. Laura, let's just sort of lay the, set the scene, as it were. You are the head of We Care Solar, a nonprofit that is working on solar energy for frontline health clinics, but you're also a doctor and an OBGYN and somewhat legendary out here in our community for birthing a lot of babies. Tell us just what it's like in a clinic in the dark first, and then when there's light.
Well, thank you, David. And thanks for being part of our board. It's our 10-year anniversary, so I'm really happy. You've been saying for such a long time you've wanted to bring together the finance community with the healthcare community, so fantastic you're doing it. Yeah, I think as a physician trained in the United States, it never even occurred to me that a hospital could be without power. And I began doing some work in Nigeria, and literally as a participant observer got to see what it is like for healthcare workers. And my specialty is obstetrics, which, as you all know, babies can deliver at any time of day or night. So what does it mean? It means that healthcare workers are literally working in close to pitch dark circumstances. They may be using candles, kerosene lanterns. I actually have a couple of slides. I can just show you pictures for a moment about what that actually can be like. They are struggling. Here's a picture in just a second. Can you see my screen right now?
Yes.
So this is basically a kerosene lantern that is in a maternity ward with rows of patients behind this light. There are mothers and babies, and no one can see what they're doing. So it means that doctors like me have to try and examine patients, diagnose patients with almost no light. It means that surgeries have to be done in the daytime with the ambient light of windows. They can't use the electricity for the lights, for the suction devices, for the cautery. And it means that healthcare workers are literally working in conditions like this. And if you look more closely, you'll see that this woman is literally holding a cell phone in her mouth to try and provide a modicum of care. And so that's really what the experience is like for health workers. It's frightening. People don't want to go to work at night. They can't use the equipment. That all depends upon power. So that's diagnostic equipment like x-rays and ultrasounds and laboratory equipment. And they can't do procedures that depend upon equipment. And now in the time of COVID, and we're all thinking about oxygen and oxygen concentrators and ventilators, it means that you may not have the power to have continuous flow of oxygen or the continuous use of a ventilator. So even when health centers are attached to things like utility grids, many of the countries in which we work do not have electricity 24 hours a day. When the World Health Organization looked at this in 2013, they found that 72% of health facilities in 8 sub-Saharan countries did not have reliable electricity. 1 in 4 had no power. A more recent review in 2018 looked at 78 low and middle income countries and found almost 60% did not have reliable power. So this is not a tiny problem, it's a big problem. And it means that tonight when the sun goes down, my colleagues around the world are going to need to try and provide life-saving care in health centers that may have no light and no electricity.
Laura, just to that point, I mean, what you've specialized in working with the midwives, also doctors, but generally nurses and midwives, who, like you say, are delivering babies. There was a thing we heard on one trip I remember where most babies are born at night for reasons that are not necessarily clear. So it's what happens when when there's a complication that, as you've told me, is fairly routine in the U.S., but a complication in a health clinic where there's not adequate lighting.
Well, David, first of all, it's really hard to even diagnose complications when you can't see what you're doing. Little complications become bigger complications. Bigger complications can result in mortality. So you see more people having complications, and you do see the loss of life. And in the health centers that we're talking about, the frontline health centers, David, things are really done in tiers. There's kind of like the village level center, and then there's more of a district hospital and referral hospitals. And so the really important role of frontline health providers is to try and take care of normal situations and then figure out who might have a complication to get them to a larger hospital where they might need the cesarean section or they might need the blood transfusion. So it's so important to be able to see what you're doing, to be able to make an appropriate diagnosis, to be able to refer someone, to be able to call for help. If there's no electricity, you may not be even to power your cell phone to be able to call for help. So we definitely see loss of light. And in the very first hospital where we brought solar power in northern Nigeria, where 3 to 8 women were already dying of complications of pregnancy and childbirth, a year after that solar electric system was put in, there was a 70% drop in maternal and newborn mortality and an increase of patients being admitted because they were no longer turned away when the health center was in darkness.
Okay, so you get a sense of the very direct, very visceral life and death sort of impact that electricity can have. WeCare, I'm very proud to say, has delivered, I think, something north of 5,000 systems in clinics. But as you say, there's something maybe like 300,000 clinics still without lighting. So that sets up the challenge that we're going to address today. And WeCare has been, and I would say a challenge for me from my ImpactAlpha, wearing my ImpactAlpha hat, not WeCare, but this challenge, because I would have thought that there would have been, for starters, a solar energy for these health clinics seems like such an obvious solution. Certainly somebody's working on it. The cost involved is not that big in the scheme of things. Surely there's some financing available. In fact, for these 10 years that we've been working together, I've been confounded, frankly, why these solutions have not emerged more robustly to solve this problem and meet the SDG 3 goals and whatnot. So let's turn to Jem Porcaro, working it from the solar energy, sustainable energy for all side. So it's an energy initiative, but now looking closely at health. What is different now?
Yeah, thanks, David, and thanks to ImpactAlpha and WeCare for convening us and inviting me. I think a lot has changed now, partly because of pioneers like WeCare Solar, who've been charting the way for this for many years. When we got involved in this space, probably about 7 years ago, you could probably count on one hand the number of entities that were working in this space. WeCare was one. If you held a webinar like this 7 years ago, you'd probably have 20% of the people on. So the good news is we've seen a groundswell of interest and activity in this space. I think a lot of that has accelerated over the last year or however many months. Now we're living in kind of our COVID reality. Clearly COVID has shine a light on the vulnerabilities and the inequities of the health system and how energy and power are so related to the provision of quality healthcare, whether it's powering oxygenators, whether it's powering ventilators, basic communication, referrals, etc. And we're really pleased because we've been kind of trying to act like an engine room, getting all of these solutions, David, to your point, connecting the dots. I think partly why, David, have seen such slow progress is this sector is not really owned and led by, or this issue isn't owned and led by one sector. So it really involves a lot of hand-holding and bridge building between principally the energy and health sectors. And that doesn't come naturally. While it's very intuitive that we should have healthcare facilities powered everywhere, we all know that folks work in silos. And so getting utilities and the ministries of power and rural energy agencies talking with ministries of health and ministries of finance around this doesn't come naturally. So we need to build these bridges. We need to make some of the really innovative technologies. We need to kind of raise awareness amongst the ministries of health and the health sector around all the available technologies and business models that we are seeing flourishing kind of in these off-grid, more commercial markets. And so I think the good news is here, even in the last year, we've seen, the likes of the World Bank, UNDP, Power Africa, WHO, practitioners, many of which are on this call, stepping up, raising kind of political ambition. The government of Nigeria is working with the World Bank to electrify several hundred healthcare facilities in response to COVID. So I think the good news is that we are seeing more activity, and I would say more sophisticated activity in this space. I think the thing that worries me a little bit is we have learned from Ebola that there is usually a window of opportunity where you can capture the momentum and the tension of these sectors. And in fact, SEFROL just published as of today a paper on the learnings from Ebola in Sierra Leone as it relates to COVID. And one of the learnings is in fact this, that we're unfortunately myopic and have this kind of short window to get the attention of governments and donors to really invest in these intersectoral issues. So my kind of plea is that let's really take advantage of this moment to once and for all strengthen and make health systems more resilient so that the next time this happens, we're not kind of on this webinar again. So I'll leave it at that, David.
Well, okay. Let me just give two quick follow-ups, and there's so many things to unpack in what you said that, in terms of, for one thing that's different from the early years of WeCare is, as you said, this very vibrant off-grid solar industry that we in ImpactAlpha have been reporting on. A flood. I mean, there's booms and busts in it, but there's been a huge amount of investment going into off-grid solar generally. Oddly, mostly it seems missing the health sector. So what would it take to make the health sector the kind of, I hate to use the phrase, but killer app for the off-grid energy industry?
Yeah, that's the million-dollar question. I think it's another way to how do we make this bankable? How do we make this of interest to private sector solution providers, to the finance community? And I think up until now, we have just been thinking about social services as we leave that to donors and philanthropies, and there's a real critical role for them. But we haven't yet kind of made the mental shift to say, wait a minute, there are some really innovative business models that are beginning to show some real success in kind of the more commercial, residential, household markets that can be adapted to these social services. It's not easy because there are some unique inherent risks associated with, providing power in these more commercial manners to ministries of health who are in themselves already very constrained in terms of the resources, right? So how do they pay for power is a real fundamental question that we need as a sector to answer. But in theory, there's nothing stopping us from attracting the same kind of private sector entities who are servicing household in rural remote areas and tapping the same kind of capital or similar type of capital and just structuring it in a way that makes it work for social services. But this kind of affordability, who pays for it and how do we mitigate these risks, I'm sure we'll talk more about, but those are kind of the crux of what we need to figure out.
Great. Great. I see Rehan. I see you nodding your head, especially when the topic of who pays for it and what the business models are. I know you've been working a lot on this business model question. That's as much an innovation, I think, in some sense as the technology itself. So tell us a little bit about what you're seeing.
Thank you, David. And I also want to start by thanking We Care Solar and ImpactAlpha for inviting me in this discussion. You know, I mean, if I link what Laura said and what James said, I mean, Laura showed a picture of a health center which was basically focusing on a kerosene lamp. So she was focusing on the light. And in the World Bank, I manage a program which is called Lighting Africa program. And I'm managing, I mean, this program is there since 2009. And what I can tell you is that whenever we went and discussed with the governments, with the Ministry of Energy, and we promoted them about this idea, about this innovative LED light technologies which can light up a household or light up a shop. And at that time, we started with a lantern and small solar systems, solar home systems. The mindset or the blockage of the mind frame that we got is that the ministries of energies were point blank telling us lighting is not electrification. And that's how they prevented the flourishment of the solar lanterns, solar home systems in their countries when their people were deprived of lights. Now, as James said, that lot has changed over the last decade, and I agree with him, a lot has changed. In fact, now as we work with many governments, we are able to convince them that when they do their national electrification strategy, they will not only focus on grid electrification, but they'll also focus on off-grid, mini-grid electrification so that they can speed up the access rate. And the countries who has adopted that actually has seen some increase in access increase. For example, Kenya, for example, Uganda, Ethiopia, they have seen it. Now, we probably need to have a similar transition, similar discussion with the health sector, because now we have to also tell them that, yes, you need to start with light, but it is not light alone. It is electrification, which doesn't have to come through a grid alone, which can come through other means. And we have innovative technologies. We have various business models. We should not be locked down into one business model, which had been the public utilities extending grid networks and providing access to people. Because when we look at those strategies, those plans, we see that they have a plan to electrify their countries in the next 20 years. Some countries which are much ambitious show that they have a plan of electrification in the next 10 years. And then we have to tell them that, okay, if that is the plan, the child who is waiting for his school to be electrified, in 10 years, he will finish his school. The mother who is waiting to deliver a baby, I mean, if she doesn't get her village electrified in the next 9 months or 8 months, he will have to deliver a baby in that darkness that Laura just showed us. So do you have to wait until 10 years, or can you think of other means, other business models that you can use today to electrify immediately all the health centers, all the schools?
Let me press you on the business models. One of the things that you were educating me about the other day was this shift from the relatively high capital expense of putting in some equipment to the service model, energy as a service, which sounds, like a modern thing, but in fact, when I plug in, to the grid here, it's energy as a service, and I pay each month my utility bill. And so, how can we turn solar, which people might think of as equipment, into a service? What's going on with that?
Yes, very good question, David. See, the rise in the solar standalone off-grid household solar industry has picked up with the introduction of pay-as-you-go model. Because before pay-as-you-go model, people who could only afford to buy solar with cash, only they were able to buy it. But with a pay-as-you-go, it mimics a kind of a service-based system, because households don't have to pay on the day one. They maybe start by paying the 10% down payment, and then they pay over 1 year or 2 years. And that's what makes it affordable for the households. And the solar companies, what we see today, is very willing to sell their solar kits or solar home systems to a household because they know the household will pay at the end of the month or end of the day. The same model, when you try to replicate for electrifying a health center, it doesn't work. Because when we tried to introduce that similar model with a private service provider, they tell me very, very honestly is that I'm happy to electrify the house of the health center worker or the school principal, but I'm not willing to electrify the health center or the school. Because if the principal or the health center worker do not pay his bill on the end of the month, I can disconnect his house remotely through my remote monitorable GIS-based technology. I can disconnect him, and the next day he will pay me back, and I will reconnect him. But the same I cannot do with a health center, because if they don't pay, and if I disconnect, next day I'll be in the headline of the newspaper that 4 babies died because the incubator was shut down because I cut off power. And because of that risk, I'm willing to take the responsibility of not electrifying them, but rather than electrifying them and taking a claim and then getting into a loss-making business. So that's where the business model actually requires coordination between the government, between the private sector, and support from the donors, so that the private sector can be clear of any risks of non-payment. Government can also make sure that it gets the service right, and then as part the service is delivered, they pay on time. And there could be other means like donor support guarantees, which can be introduced to at the same time mitigate the risk of non-payment. So this is a business model that we are discussing. But again, we need to have willing governments who would like to take up that business model, but make it work. But what we have been trying to convince them that if we are unable to adopt to a business model which unlocks the potential of private sector financing these investments, donors alone, governments alone cannot electrify this whole area. Because if you only look at the basic needs of electrifying these health centers and schools, the demand of financing is more than $10 to $11 billion in the next 10 years. That means you need $1 billion flowing in every year if you want to electrify all health centers and schools by 2030. That's the amount of funding no government or donor can provide. We need private sector to come in.
All right, that's a perfect transition to you, Phyllis, from UBS Optimist. Both Jem and Rehan came back to somebody's got to pay for this, and the economics of the at a strict business level there's a gap, and that obviously means that some kind of donor, as Rehan was saying. So UBS Optimist, maybe you just explain a little bit about where you sit and whatnot, but also the ways in which you're seeing donors step up in these regards.
Great. Well, thanks for having me, David. And it's great to be back with you, Laura. We've been working with Laura for almost 9 years now. So we are a big supporter of the work that she and the rest of you are trying to do to bring electricity and to electrify health centers. So UBS Optimist Foundation is actually quite a unique beast. It sits within UBS, which is the largest wealth management firm globally, which means, in essence, we manage wealthy people's money. And what we try to do at the foundation, which is actually a service for our clients, it's not an in-house corporate foundation. We're trying to bring more money and better money to solve some of the world's biggest critical issues, particularly around the SDGs. So I'm a big fan of SDG 17, which is all, as you said, David, about partnerships and bringing the private sector in. So how do we do that? Well, one thing that we know from our clients is that while 90% of our largest clients are giving philanthropically, fewer than 20% of them are actually satisfied that they're making an impact, which is a real tragedy. And if we think about impact investing, which many of you on this call I know are experts in, we also see when we've surveyed our clients that there's all sorts of confusion about what does that impact mean? How are we measuring it? How do we know if we've achieved it? And so that is the nut that we're trying to crack. And we do that by testing new models of financing. And again, we're trying to bring more money and better money. So let me give you one example. You mentioned, David, in your intro that we launched the first development impact bond. But we also launched the first social success note. And that is that with basically with a very small amount of capital, we were able to bring in private investment so that philanthropy would be paid out only if the social impact that is measurable is actually realized. So how does this work? We partnered with Unis Social Business, the Rockefeller Foundation, and Impact Water for this first social success note. And as I said, it's basically an innovative pay-for-performance financing solution that is driving return-seeking capital to social businesses that are looking at some of the most entrenched challenges. And so why was this particular initiative important? It's called Impact Water. It was there to address the lack of clean drinking water in schools in Uganda. And we all know that without clean drinking water, in schools in particular, children are much more likely to get sick and to even die from waterborne and sanitation-related illnesses such as diarrhea, malaria. And schools are often the source of this disease transmission. So without the supply of safe drinking water, they're very susceptible to this. And this is virtually non-existent in many of the schools. And we also know the importance of clean water in hand washing, which I certainly don't have to remind anybody about. So this organization, Impact Water, is a social business, and they sell and install water filtration systems in Uganda. And so they borrowed money from our foundation, and this was funded by our clients. And we structured a loan, and the Rockefeller Foundation was providing the outcome payment for each filtration system. And so what this does is that this note blends funds from donor organizations, governments, private debt, and equity. And we're trying to install about 3,600 water systems into schools in Uganda, which would serve about 1.5 million children. And so the loan to Impact Water gets reduced, the interest payments are reduced based on hitting installation targets, along with other water and health-related goals. And so this provides incentives for private capital to finance the early stage social SMEs, particularly those that need debt to expand operations.
Phyllis, let me break in, because this is, I love these wonky financial deals, as you know, but I think the takeaway here is that there are innovative financing mechanisms developing that, as you say, both blend private and public and are outcome focused, and that bring together stakeholders, as Jem and Rehan were advocating. Is there and I know we have actually the UN, maybe some UNDP guests as well that maybe can chime in a little bit later. Coordinated donor, donor coordination, such that there is a layer that could help pay for solar through all of these mechanisms: energy as a service, development impact bonds, pay for performance, results-based finance, all of these things. But somebody's going to have to put in some extra money, put it that way, a subsidy to make it work. That can be, as you say, donor countries, also private donors, philanthropies, individuals, what have you. Do you see on the horizon that kind of coordination to make the financing models that are emerging as we're hearing, is that donor interest there? And just to put it in context, Rehan gave us the number, $1 billion a year. Sounds like a big number on one hand, but remind us what UBS's assets under management and wealth management are.
So you know what, our assets under management are more than $2.5 trillion. So imagine if we just got a small portion of that. And that's what we're trying to do. And so this year we'll raise probably close to 130 million. Now, it's not $1 billion, but it's getting there. And that's just one financial institution. And we are seeing coordinated efforts. So there is an outcome funders group right now with players like the World Bank, like USAID, DFID, a lot of the bilateral and multilaterals who are coming together to build a large outcomes fund that is going to pay for things like healthcare. It's focused specifically on SDGs 3 and 4. And that fund should be around $200 to $300 million. So, not $1 billion, but we're just one financial institution. So we just need a few more to step up and try to draw on this capital.
Great, thank you. That was exactly what I was hoping you would say, that there is motion on this level. And Michael Liebrich, let's leave it to you to sort of bring things together. And what I want to guide you towards is this notion that, as everybody's saying, there's different layers in the capital stack, in the value chain, as it were. There seems to be activity happening at each of them. It's in some ways similar to the earlier days of renewable energy industry developing that you of all people have tracked very closely through new energy finance back in the day. Just give us a kind of a guidepost or something to understand where we're at in the development and where this might be going.
Okay, thank you very much, and it's great to be here. What an extraordinary group of people. I've been reading the chat, and frankly, the people on the chat can fix this. So I hope you're going to sort of circulate all those introductions because it's an extraordinary group. And already what I've heard, never mind the speakers as well. Just for those who might not know, I was very involved with SE for All way back from about 2008 through till the point where it became first SE for All, and then it became SDG 7. So I introduced myself, I say, sort of pale male still SDG 7er. I really am very committed to SDG 7. But the other thing, before I answer your question, is that I sort of have swanned around doing, advising secretary generals and talking to energy ministers and big banks that I advise and huge energy companies. But also, just for context, I did a project a few years back in Sierra Leone, which was just by coincidence. I heard about a neonatal clinic that didn't have reliable power. And as a result, babies were dying for lack of heat, for lack of oxygen. So I kind of dived right into this. And now I'm back up at this kind of, slightly ethereal level, trying to pull together all those strands that you talked about. All of the case studies are there. The technology is there. Laura has done 5,000 of these things, wants to do 300,000. That sounds daunting. Let me tell you, one of the lessons from the early days of the clean energy space is these things can be geometric because it's all distributed. Then the fact that you've only done 5,000, you don't divide the remainder by 5,000. You look at the growth rates. Right? And that's one thing. Amazing to listen to, to Rehan, to Phyllis, because the pieces are there. And before Rehan spoke, I was doing my own little calculations. You've got 300,000 more clinics and anything from, $5,000 for a solar suitcase to $100,000 for the sort of thing that we did in Sierra Leone. The total is somewhere between sort of 2 billion and 30 billion, and you do all of them. The piece that I have not heard yet that I think is really important to inject into this is the getting a donor to give money each year, getting a government to give money, to put some budget each year, is not as useful in terms of financing this as getting long-term commitments. So if you can get 10 years, if you can get 7 years, that's better than 1. If you can get 10, that's better than 7. If you can get 15, you are home and dry. And so I think the sorts of structures, I'm always come back to the Garvey structure. We needed to solve the AIDS problem then. And so instead of just raising money every year, you get a commitment over a period, and then you can capitalize it in the financial markets. And we could spend, whether it's 2 billion or whether it's 30 billion, with the sort of geometric growth that we know that the energy sector can deliver, then certainly that solves the finance problem, it solves the technology problem. Does it solve all the stakeholder issues? Does it solve the sheer complexity? One of the things that we discovered doing Sierra Leone, you all, lived through it, just complexity of import duties, complexity of stakeholders, of corruption, of all sorts of things. No, it doesn't solve that. But that's definitely, it feels to me like the key to real scale is getting these long-term commitments. One other thing I would say though, before I get, if we're kind of putting together a capital stack, there's another source of capital which we've not talked about, which is, we talked about donors, we talked about governments, we talked about, trying to turn that into long-term sources and streams. But the other one is, of course, there is a huge amount being spent, whether it's in the healthcare system or whether it is in the school system, already on kerosene and, you know, crappy solutions that are bad for air quality, they don't work, and they're expensive, and people are spending that money. So there also has to be a commitment from the host nation, the host ministry, the host institution, and the host institution's customers and local stakeholders to say, we will put that money into the pot for some period, because you can capitalize that, even though their credit rating is not the same as UBS or as UBS's fabulous clients. You can also create a piece of the capital stack there by not spending that money and putting into these just much, much better solutions. And finally, I want to just say, Laura, your number, you need the data on how effective this stuff is. And, you know, we have the problem we had in Sierra Leone is we didn't have time to get the before data. So we have an estimate of lives saved, mortality improved, and suppressed demand. We got all of that, but it's only approximate. It's not really sort of industrial quality data collection that says, you do X, you save Y lives, or Y disability, you know, Z disabilities amongst kids, or whatever it is. And I think with that sort of data, it's all disparate and scattered. That feels something that's very cheap. I mean, in the sense of, you know, $3, $5, $10 million, $20 million ought to get us so far up that data that it becomes just, you know, that going to a government and saying, look, don't give 20 million, give 5 million a year for 10, 15 years. Great. Give 20 million a year for 10, 15 years, because that you can take to, you know, Goldman Sachs, UBS, Morgan Stanley, but you could turn that into hundreds and hundreds of millions or even billions very easily if you can get those sorts of longer term commitments.
Great, great. Well, thank you all. One of the things, there's as we can see, there's a lot of layers here and a lot of players. One of the key players that you've all raised, and we are lucky to have a representative, is the Ministries of Health. And Laura, you have been working with Uganda. We Care has I think an MOU with the Ministry of Health in Uganda for what you call light every birth, which is literally to get some lighting, initial lighting into every clinic. And Dr. Charles Olaro, I think is with us. Is that right, Dr. Olaro? You may be muted. I can't see you on my screen. Dr. Olaro is...
Hello, hello.
Ah, there you are. Hi, welcome, Dr. Olaro.
Thank you.
You are with the Ministry of Health in Uganda, and there've been questions, as you've heard, about how the Ministries of Health can prioritize the lighting of primary health clinics. And if you could just share with us some of what you're doing in Uganda and some of what you need.
Thank you for asking me to join this. Definitely, as the ministry, it looks as all the initiatives which should be really tailor-made and to be able to see that Ugandans receive the best healthcare service in the country. But specifically looking at aspects of energy, clean energy, specifically here solar, is one of those most effective ways that the Ministry of Health has focused on to ensure significant improvement in healthcare delivery, especially at lower health facilities, the primary healthcare facilities, which we term as the Health Center 2, Health Center 3, Health Center 4s. And currently the ministry is working on upgrading about 321 health facilities, health center 3s. And this provide maternal health care services. But specifically, we're looking at the solar energy for first, in addition to providing light, we're also looking at being able to power fridges for blood, for vaccines, but also for medicines like oxytocin and insulin. And this is really key if we have to improve services down there. So the approach right now, definitely most of us, as you agree, that most of the funding is really from development partners. And currently, if you look at the one which is the ERT Project 3, which is funded by the World Bank, and this is in partnership with the Ministry of Energy and Ministry of Health and Ministry of Finance. And the issues which normally come definitely is, I think, which definitely is a concern for the donors, and which I heard is the aspect of really governments or ministries wanting always the partners to put in additions. I think the issues here come on the aspect of it, how is the partnership structured? Because if the roles of each of the partners is well indicated, like this particular project, there are roles of the Ministry of Health, which is aspect of maintenance, aspect of payment of taxes, and the aspect of user training. And while Ministry of Finance definitely has to avail resources. In my experience, even when these are well structured like that, the issue normally comes that the major culprit is the Ministry of Finance, which definitely sometimes delays to release the money which is necessary for meeting some of the obligations of the contract. So I think if we are able to address that, then we can be able to see that we can be able to have sustainable energy systems. But also at the same time, we need to be able to see that what are those systems which are desirable or which have a longevity to be used in our settings, like probably looking at a 5-year project before you are able to either to replace the batteries. So I think the partnership should be structured, and we think that each partner should be able to meet its part of the debate, and the ministry, as I indicated, the user training, pay taxes, and Ministry of Finance definitely has to avail these resources, so that we don't get the partners getting frustrated and looking like they are really all the responsibilities pushed to them. So I think really we need to get it into this in true spirit of partnership, and I think that's what Uganda as Ugandan government would want really to work on, and see that we can be able to sustain this system and improve services at those low levels.
Thank you. Dr. Olaro, this is Dr. Stachel again. I just want to mention that one of the things we've done with Light Every Birth is really look at a national initiative rather than saying that only specific health centers can get the light and the power that's needed to save lives in childbirth, but to say what would it look like to reach every single frontline health clinic that's in need of reliable electricity. And Dr. Olaro, I think one of the things that's been so impressive to me is really how that partnership has looked, that we've brought in the Ministry of Energy, that we've brought in the Ministry of Finance, that we've brought in the district health technicians to provide training so people actually know how to take care of the equipment, that we've worked together to develop supply chains, that we really have created quite a coalition, because it does take people working together rather than a lot of siloed approaches, which I think often happens in the donor world. People have their pet project, they work with a specific institution that may be addressing healthcare like in one district or in a portion of one district, and then you have lots of uncoordinated projects going on. And Dr. Olaro, it seems to me like Uganda has really done a good job of trying to pull that together so that there is greater coordination, including with the steering committee that's looking at energy and health within the ministry. Can you comment on that?
David, I would like to also come in, because I would like to say that Mr. Dr. Olaro, or the Ministry of Health in Uganda, is one of the leaders that we see in Africa. I mean, he referred to the ERT3 project, which is a bank-funded project, and I work in that project. So we see how Ministry of Health in Uganda is embracing these new innovative technologies, where the other governments or other countries are not that keen, because everybody wants to see that where has it been tried and tested before. But we see this different in Uganda, because they are willing to work with us. The business model that I talked about, I mean, the permanent secretary of Ministry of Health actually sent a letter where they have asked that this is a very innovative business model, but they would like to get clarification that how this business model, which talks about 10 to 15 years of a service contract, but all the donor funds or projects come for a 5-year tenure. So how can beyond the 5-year these payment challenges can be looked at? So what I wanted to say is that they are thinking in it from a developmental challenge point of view, and they're working with us. And we need more like Dr. Ola Rose to become an ambassador, so that all our other countries and clients can see the example of Uganda and then embrace these new business models.
Let me just add another layer here, and then we can sort of open it up. But as we were doing the reporting for this call, 2 examples kept popping up, and we wanted to just make sure that everybody can watch them. One is from Norway with the Differ Group, and I think Kjetil Royn, I'm sure I'm mispronouncing that, I think is with us. Kjetil, if you're on, pop up. And then also Green Street Africa, which is organized by Green Max Advisor. And I think Cliff Aaron may be with us. We just wrote that, oh, there you are. Hi, we just wrote that up a bit because it was selected recently to be part of something called the Global Innovation Lab for Climate Finance. I might have the order of that mixed up, as a financial model. They both have this aspect of, as I think you were saying, Rehan, kind of a long-term, and Michael, you were pointing to, it's a long-term power purchase agreement signed, I think, by ministries of health that that guarantees payment for electricity generated at these distributed health clinics. So basically taking a portfolio approach, bringing a lot of health centers together, rolling that all up into one power purchase agreement, which the Ministry of Health agrees to pay for. So there's now a revenue stream for this that's at the country level, and Laura was pointing us towards the importance of these country level agreements. So that seems to be kind of an emerging, I know there's differences between Differ and Green Street at the margins, and maybe we can get into that, but that seems to be an emerging model to bring together lots of small projects, have a payer that agrees to pay, and then the question always is, you know, how do you pay? So, so that's, I think, what's kind of on the table now, and then that brings, you know, in the donor financing and the subsidies as well. So let's have at it. If Kjetil or Cliff, you want to say something about that, and where you see the opportunities and the obstacles.
Sure, with pleasure, and thanks so much for the opportunity to be here today. We're big believers. As you can see, I have a lot of gray hair, and from that gray hair comes some institutional memory that we don't always have to reinvent the wheel every time we're faced with problems like this. And in fact, there is a model for energy as a service in the public sector that has been developed over 30, 40 years, first in industrialized countries and now widely utilized throughout emerging markets, and that's energy services in the ESCO model, focusing on energy efficiency for public buildings. And there's many striking similarities between those models, and what we've tried to do is tweak what we call the super ESCO approach in energy efficiency, which is a public-private partnership between companies that can, private sector companies that can aggregate opportunities together with a public sector partner and prepare them for implementation by what we call sub-ESCOs, in this case, you know, IPPs and companies working in either the C&I solar or other aspects of off-grid solar space, have them enter into these long-term energy services agreements or PPA agreements, have this all financed most efficiently through local capital markets. So do a local currency bond issue, because when you're dealing with governments in Africa, it's critical that the financing be in local currency and not hard currency. And finally, to have the payment system backed up with DFI and donor guarantee facilities. So we've developed Green Street Africa with a pilot program in Nigeria, where our partners are the Rural Electrification Agency and InfraCredit, which is a multi-donor facility to issue insured infrastructure bonds. And we're going to start off by doing 6 hospital facilities and then expand it to smaller health clinics in Nigeria and other countries in the region.
Great, thank you. Michael, and then I just want to sort of say that we're now in the with a few minutes remaining, and we will go over as Zulema said. So don't log off at the hour. But let's bring in the audience as well. But Michael, give us your thoughts.
Yes, I just wondered, there was a comment actually in one of the chat comments, and Lihi Schooler, I hope I pronounced that right, asking about technology, and it triggered for me a thought that actually, whilst I've said that all the different pieces are in the room here, there are actually 2 players that are missing. And as we think about structuring the sort of, these sorts of, the capital stack that does this, they could also be contributing. That is the local utility or energy company, because even if it's a distributed solution, very often we've got to think about, we've got to stop thinking about it as being, it's either a disconnected solution or it's a connected solution, and that's that. Because back to Sierra Leone, that was a clinic that actually had electricity, but it was unreliable. And there are many, many of these schools and so on that are in that sort of situation. And clinics.
Well, it's even more complicated than that, because there's not only some of them have some grid which may be reliable, as people said. Some of them have had multiple solar systems installed over the course of years that are now broken down. I think let's bring in Chetel from Differ.
One second, I want to finish my intervention, because there is another player, which is and then we have the complete cast of characters. And that is the technology providers. And there's so much innovation going on that, and the Johnson & Johnsons and the GEs, the equipment providers, they are still dumping equipment that is essentially designed for centralized large grids. And they're not yet really designing for, designed for solar. This is something that Ignite Solar is working on, just appliances that work at low voltage, highly efficient, and therefore just massively shrink and reduce this challenge. And of course, some of these companies at the top end are very big companies. They have balance sheets and they benefit enormously from electrification, but they're not around the table here in this sort of discussion. And I think they need to be brought in.
Beautiful. So yeah, medical devices, and one of the interesting issues is whether the first power, as WeCare has found, is a sort of energy utility type solution, or whether it's really almost a medical device, and therefore commands commands and deserves some level of support to enable the other devices, as you say. I just wanted to say, Chetel, you've had some experience with this multiple systems. All in the compounding, and many of them broken down. Are you with us?
Yes, I am. Yes, just a few words, and I could echo Cliff quite a bit. I don't have gray hair. I don't have any hair at all. So it's obviously something here. Well. Originally, I'm coming from the carbon world, and in the carbon world, POAs are program of activities is a key thing, where you are bundling several small projects into one group in a way. And that's the idea behind the approach that we have, that to bundle many small systems into one big project and get that financed. I do not think that financing is the key challenge here. It's as Jem said, it's to get the project bankable. And in order to get that, we have to look at the utility scale business, because there you have the PPAs, and you have the guarantees for the PPAs, and you have the guarantees for the guarantees, so that everything is in a way for the IPPs and the project developers. It's in a way they do not start working before they have everything in place financially. That's the way we have to move towards distributed energy solutions as well.
Let me just break in, because we're at the top of the hour. Sure. and we can open this up a little bit in the what we call the after party or what have you. Think of it as sort of hanging out in the hallway. There's been so much going on here. So obviously, if you have another appointment, you can obviously leave at this point with no offense taken. But if you can stay, let's just keep the conversation going, and I will play a little bit less of a role here and let people pipe up. I will say that there's a few people that we invited, and I would like, if you do want to say anything, that includes our friends from the UNDP and Solar for Health, who are working on this kind of donor coordination. It includes Benin from Kois Invest, which has worked on this problem. It also includes Asaf Mahmoud from SEMA, which is working on an energy access relief fund for off-grid providers more generally. So anyway, there's a lot of talent in this room, so to speak, and I don't want to let you all go without meeting each other and chiming in. Laura, why don't you just give us a little bit of your sort of wrap up here and what you hope folks can kind of do, after this call.
Okay, sure. Thanks, David. Thanks to everybody who participated so far as panelists, and I do encourage people to stay on for the after party. At We Care Solar, we really are taking on the initiative of Light Every Birth, which is a country by country initiative to literally reach every health facility with that first 100 watts of electricity. There's some power. There's efficient medical devices that we pack within the form factor of a suitcase that has medical quality lights, fetal Doppler, infrared thermometer, and it's an immediate solution to clearly a larger problem. But we actually have addressed the issues like training and sustainability and supply chains, and we are showing that it is possible to do this. We've reached 5,200 health facilities, and I kind of think that even though our solution is small and compact, it can be a model for how you can work collaboratively, how you can work at country levels, how you can bring in UN agencies, international NGOs, government partners. We just signed a tri-party agreement in Sierra Leone with the Ministry of Health and the Ministry of Energy together. So I believe it's possible. I think there's been some great ideas for financing that have come up. We want to continue the conversation. So anyone that would like to join us with a coalition, I'll put up my email, and I think we can continue to have these conversations post the meeting. And I believe Jem also has some other ideas for people that want to be continuing to discuss these things.
Yes, anybody who has follow-ons, obviously put that in the chat. Jem, do you want to say something specific?
No, I mean, I certainly could talk to what's to come and what, give some examples of things to look forward to for the group, but I can do that later.
No. I think people would appreciate that, and we always like to leave it on a sort of action orientation.
Yeah, no, I was just going to only say, I mean, this has been a great discussion, and what we're trying to do at SC for All is in essence, we want to be a champion of all these great ideas. We want to be a catalyst and a bridge. So, we talked a lot about business models. I would encourage you to take a look at a report we put out last year called Lasting Impact, which literally evaluated a lot of these different business models and actually put forth some business models along the lines of what you've heard from Cliff And so we're trying to seed some of this. And we're putting together an update to that, which is in essence now going to focus on this kind of energy as a service long-term PPA model. And we're going to be featuring what Cliff and others are doing on this. So hopefully going to try to aggregate and codify this great discussion into something that can be a springboard for further innovation and advancement. I saw Michael ask, talking about technology. I would encourage you to take a look at our solutions catalog that has 25 plus actual specific technologies that we've aggregated with the World Bank that are deployable, scalable. So there are resources out there. I would encourage you to take a look at the SC for All website. That's what we're trying to do. Yeah, I'll leave it at that, David.
Great. So I think you get there are some acronyms slung around. I think a fair amount of complexity. I think you probably get the sense all from that this is a complex challenge with both, it's not just a kind of fancy flowchart of financing, but that there's a lot of nitty-gritty obstacles to overcome. But I also think you possibly got the sense that there's some energy for this. I always think, hey, the tougher the challenge, the better the solution. If you can make it work for frontline public primary health clinics in Africa and South Asia, you'll be great in those easy markets that may be the heart of your business model. So all of you who are working away at this, I salute you, but I also want to say that ImpactAlpha wants to continue to cover this. I mean, let's treat this as the ultimate kind of catalytic capital design challenge and have all the brain power of the ImpactAlpha community put to work on this as well. So again, stick around. We'll leave the Zoom chat open as long as the conversation is flowing, probably about 20 minutes or so. Laura, please, if you can stick around a little bit, I think people would love to get to know you more. It's been a great treat to bring my two worlds together of ImpactAlpha and We Care Solar. So thanks to all of you, and I'll kind of take a little bit back seat, but Bill Brent or Assad or Benin, if you want to jump in now, the floor is open. I think Zulema, maybe did you want to stop the recording, or there's no necessary real need to? But anyway, we'd have a drink, but it's 2020, so. Thanks all.
I would love to actually hear from Power for All. I believe that William and Christina are on the phone. If either of you want to talk about the work you're doing to really advocate for renewable energy for healthcare, we'd love to hear that too.
Yeah, thanks, Laura. This is William. Great conversation. I mean, what an amazing group of people. Really inspiring. So thanks for pulling this all together. And David, you did an amazing job of navigating that conversation. So yeah, kudos to you. So I think, it's been alluded to, but there's a lot of disconnect at the country level between the various stakeholders. And one of the key focus areas of Power for All's work is really trying to mobilize different stakeholders, bring them together first and foremost, and then mobilize them towards a common vision. And so we started to do that work around health clinic solarization in India earlier this year in April. Where we brought together about half and half, 20 organizations working domestically from the healthcare sector and the renewable energy sector, and worked together with them to try and facilitate what that common vision looked like. First, identifying what the barriers were to solving the problem in India, where there's still 39,000 sub-centers that are unelectrified, and also bringing together government, donors, other multilateral agencies, domestic agencies to have a national roundtable on this topic, which we did in August. And from that, produce what we call the beginning of a solutions brief. Essentially, that's a consensus document based on those conversations that then we can use at the state level to try and work with state governments where all of the action needs to happen to take what's been done in Chhattisgarh and other places in India and replicate that. And now we're in the process of doing that in sub-Saharan Africa as well in a number of countries. So if anybody's interested in working with us to do that at the country level, would love to hear from you. And if it's Uganda or other countries that are looking to try and elevate their work regionally and globally, we'd be happy to do that as well. So thanks again.
Phyllis, do you have a country focus? I know you've worked a lot in Liberia, as I understand.
We're doing a lot in Liberia, and we used to focus primarily in Western Africa, but not anymore. What we're doing in social finance, actually, in this larger blended finance fund that I mentioned, is actually going to address sub-Saharan Africa and Southeast Asia. So it will be quite broad.
Great. This country level innovation that WeCare has worked on, and others have mentioned, I think is the key, and it does let you pop up to the multilateral financing level. I don't know whether the UNDP folks are here. Matteo, are you here, or Abdullah?
Hi, David. Yes, I'm still here.
Ah, good. I'm taken by this donor collaborative idea, and that there is this pool which existed already for energy, which may have existed already for health, which may be replenished or topped up now as a COVID emergency sort of response. Obviously, there's an SDG 3 push on, and countries, and as Phyllis has said, you know, private donors as well. The Gates Foundation comes up in any conversation. Is there the money there to do it at this level? Rehan says it's only $1 billion a year.
Well, look, I think the speakers have addressed a lot of this aspect and issue, you know, and challenge of on one hand, the cooperation and partnership of different actors to come up with a coordinated approach to respond to the electrification of healthcare issues. And then there is the aspect of long-term financing. You know? So I think these two elements are key, and this is what we are seeking to address in a set of initial countries, also looking to move away from a business model which we have been implemented in the past, which is basically the purchase and transfer of solar assets to the health facilities. Because we realize now that the challenge with this model is that once you install those technologies, you have a contract with the service provider that can provide O&M during 2 to maximum 3 years, and then the assets are in hands of the partner government, the Ministry of Health, or the health clinic itself, and there is a challenge for maintaining those assets. So we're trying to move away from this sort of traditional donor funding approach through an energy as a service model. But there, you know, we have been engaging a lot with investors, with private sector actors, etc. And there's a strong focus on how do you finance the ESP so that, you know, they can channel resources to be able to cover the CapEx expenses and then cover the OpEx. But at the end, for this model to work, you still need to have an off-taker or counterpart which has the ability to pay for these services. No? And this is something, you know, unfortunately, we cannot necessarily solve only through private sector investment, and we require some level of public investment. So this is where we are coming in now and looking at solving this side of the equation, how to channel long-term resources to be able to you know, support or subsidize in a way the ability to pay of certain government to contract these energy services, and then for the energy service provider to be able to have sort of a guaranteed PPA or a solid PPA with an off-taker to be able to mobilize investment from the private sector to cover the CapEx and the OpEx. So the challenge in that model is, you know, this long-term financing and how we can pool different resources to be able to sustain that long-term financing that allows the government, the Ministry of Health, etc., to enter into these long-term agreements with the energy service provider. So we are working in that, and we are trying to set up that model, and also, you know, we are in discussion with some funders that could potentially be able to provide long-term financing through climate finance, and we are looking at different options for that.
David, if you may allow.
I just wanted to say one thing, because the phrase has come up. I always make it my job to tell people what the acronyms stand for. PPA is a power purchase agreement, very common in the energy world. And it's basically a 20-year commitment, as I understand, to pay for the power that the system, the project develops. And that gives the project developer the ability to finance that project over those 20 years because there's a revenue stream. So if you take away PPA from this call, that's your word of the day.
Thank you, David. What I wanted to come just after Matteo, because what he said is exactly on the spot. That is the issue, or that is the problem of the day. I mean, and then he has also referred about the coordination problem that we are seeing in the government level, because, and also the coordination which is needed among the donors, government and private sector. That's actually key. I would like to refer to the picture, one of the picture that Laura again showed at the very beginning. There's a picture of a operation theater or surgery theater with surgery or specialized lights. And Laura said that health center did not have electricity. The problem I wanted to focus is that while that health center did not have electricity, somebody gave them money to buy that specialized light. The point I'm trying to make is that I'm not worried about the money part, the $1 billion or 10, 11 billion. I'm not worried about that. I think that money will flow, provided we have the right business model, right enabling environment in place. And that's why I think we all need to work together to at least change the mindset of all of us, the donors, the private sector, the government, that it is not capital investment. I mean, providing that light, maybe it ticked the checkbox of somebody's, but it did not solve the problem. So the point I want to make is that let's bang our heads together to see how can we actually solve the problem, not just tick a box that, okay, I have provided so many solar lamps or solar lights in that health center. But we need to move or transition to a model where there will be performance-based contracts. There will be a monitoring system. Governments will somehow be able to confirm that, yes, that health center receives 24/7 electricity. The health center doesn't only receive a vaccination fridge or a blood bank, but it also have electricity to operate them and maintain them and provide service to the people. So we need to make that transition, David.
David, if I may, can I jump in and just build on Rehan? Since this is the after party, maybe we can kind of get a little bit more into the weeds. But I think this is a really important point that Rehan is making. And I would argue that even if that picture of the light if that health facility were connected to the grid, it doesn't necessarily mean that that light would always work and the electricity would flow, or that health facility would be able to pay for that power. So I think in trying to design a bankable business model, we really have to reach out to the ministries of health and the ministries of finance and find a wholesale solution to this issue of how utilities like water, power are paid for. Because it's not as simple as just saying, well, because they're off grid, that's the problem. Even those that are on grid, I mean, as many of us on this call know, the majority of utilities in Africa are bankrupt. And some part of that story has to do with a free pass that some ministry, some social services get when it comes to paying their utility bill. And so this is really the systemic root issues that from a policy point of view need to be addressed. And that's why I think it really is incumbent that we work with our health colleagues, our finance colleagues within the bank, within our host governments to solve these issues. Because I think until we do, to some extent, we're meddling around the edges.
Can I just make a point since people are bringing up that slide? I just want to actually show you that hospital that I was showing you, the one that had the no light for the operating room, it's the one on the right. So there's different tiers of healthcare. There's the most village level on the left, kind of the medium level, larger health center, and then this is a hospital. And if you look at this picture, there are actually grid lines. They were connected to the grid, and the box behind the building is a generator. So they both had the electric grid and they had the generator. The electric grid only worked 12 hours a day. The generator required fuel. They get a certain budget for fuel and they have to make that last for the whole month. And honestly, they only had fuel at most for a couple hours a day. And there were situations where literally we did a C-section. I was doing it at night. The lights went out. There was no money for fuel for that generator. If I didn't have a flashlight, the whole thing would have been finished in complete darkness. And this, the other thing I just want to point out is that this issue of equipment that Michael brought up, that Rehan brought up, it is so important. And there's different kinds of equipment at different types of health facilities. And I can't stress enough what Michael Liebrich was talking about, that it's so much better to create energy efficient devices. It's often cheaper to buy new devices than to try and create a giant renewable energy system to try and power an inefficient thing. And for example, this one picture on the right, you see an ultrasound machine. That's what it looked like. You know, there's these big ultrasound machines, they might be 400 watts, and you can get a handheld device on an iPad that does an equally good job now that maybe is 20 watts. So that's really, really important. And just to remind people, you know, this is really what people are working with now, handheld solutions, generators, dysfunctional power grids that Jem was talking about. It's really true. And these clinics are very far apart from each other. So the idea of having a distributed, independent source of power is just so very good. And that's the things that we've been talking about here. And I really believe we can do it. I really feel like there is if there's the will, there's certainly the government's being interested in it. I think if we can get the people that are on this call and our friends who are in finance to think about and put our heads together, I absolutely think this is solvable in our lifetime.
Can I come back in on the point about energy efficient devices and technology? I do apologize, David, because I did push myself back in for another intervention, but I really did think back that, you know, that we needed to get that out there. My example from Sierra Leone, UNICEF gave about $15,000 worth of baby warmers and oxygen separators to the unit. I think we just calculated it roughly. We had to spend $120,000 on the power supply, right? So even if the equipment, if we'd have had to rip that out, throw it away and give them twice as energy efficient equipment, but reduce the cost of the system to $50,000, $60,000, or even, you know, perhaps, we don't even know how cheaply it could have been done had the equipment been, you know, designed to be appropriate. The other thing, so there's part of what we need to do though, the big challenge is that out there we've got lots of really well-meaning people, governments, donors, UNICEF. They didn't give in energy inefficient equipment because they were, you know, bad, evil people, or even because they were stupid people. They're not. What they didn't understand though is the footprint of their activities. They're not looking at a whole sort of system solution and saying, what are we trying to do? We're trying to deliver a health service. What's the cheapest way to, you know, to do that? And then really making sure that you've got the system boundary correctly defined to include the energy system. That was, you know, and as long as there's people who think that's somebody else's problem, we can just tick off the list, say, did we do something in country X? Yes. How many did we do? Yes. Then you've got to have this problem is not going to go away. It's not going to go away. So I think there's a job of work. You know, I was kind of, who's not round the table is also just the generic non-specialists who are sort of trying to do good, as well as all the different financial players. We've got to bang some heads together at scale here, or we're going to spend, you know, we'll make, my prognosis, my forecast would be that, you know, Laura will have done, instead of 5, in 10 years, she'll have done 50, right? And we'll be 10 times further along, and Jem will have done great work, and Rehan will have done great work, and whatever, but there will still be 300,000 left to do, unless we really kind of find something that, you know, there's got to be a kind of step change, and it has to come, no individual group or stakeholder set is going to deliver that, because it is such a kind of complex or but starting by defining success as the delivery of the service, not the gigawatts of centralized power station, that's old school, and not the ticks against the lists of either homes or hospitals, that's current, we've got to move it all the way to, do doctors have access reliably to ultrasound? Do babies have access reliably to oxygen? And that's the metric that we need. And the good news, of course, is that with digital technology, we can start to measure at that level, right? With machine learning, we could probably put that across all sorts of signals and data that's out there. And, you know, I talked about upgrading our knowledge of the success and the value of interventions. There's a whole set of other things. You know, why isn't IBM on this call thinking, well, that's a good idea. Yeah, we could probably create some energy metrics for the health service around the developing world. I mean, it might not even be that difficult anymore. That's the scary thing. Or some get IBM together with Vodafone and say, look, tell us how many doctors there are operating in Africa who do not have access to an ultrasound. Figure it out. It can't be that hard. And if you need to get ultrasounds to be redesigned so that they ping or they do so, just figure it out.
I love that energy, Michael, because you're bringing the exponential, as you said, or geometric scale of the solution that has, it's not fantasy. It's actually worked in other adjacent markets, and it just needs to be harnessed to this. I'll tell you what I've noodled on this past couple of weeks as we've been working on this call. A layer that is and I keep coming back to this, a layer that is a subsidy layer. I think that everybody I've heard has said that there needs to be some additional money put into the system. And one idea is it could be a guarantee. Rehan, when I laid this out to him, said, you know, a guarantee only works if you believe that there actually is a revenue source underneath it that you're guaranteeing. So maybe it's literally a revenue subsidy to help the ministries of health pay that bill that makes the financing work. And that would be some kind of, you know, multilateral donor, World Bank level of subsidy. As Rehan said, it's not big in the scheme of things. If what we're talking about is $1 billion, or as you back of the envelope said, a couple or 3 billion a year. So it's not a huge amount in the scheme of sustainable development goal type initiatives. And that you just justify that subsidy because on the one hand, there's a COVID crisis on, and the other hand, you have maternal mortality goals that Laura knows well, and that you're going to subsidize healthcare anyway. And then on the other hand, you're also going to subsidize utilities anyway, because you're already doing that in most of Africa, as various people have said. So you're moving the subsidies through the health system and then empowering and financing and enabling these solar project developers that Green Street and others and Differ Group and others have mobilized. So it all seems to be there in my mind.
Yeah. But can I make a general point about the sort of aid, development, donor, sustainable finance blob? I'll use that word. You know,
that's a technical word.
I'll use it in a friendly, in a respectful, and you know, I'm part of it. Okay, so it's not. Don't anybody take offense. There's a lot of talk about these sort of debt models, and one thing we have to understand is that debt, a bond, debt, all of these things, they all have to be repaid. They can be repaid by the person you lend to, or they can be repaid by somebody else. They can be. You can have a guarantee, which makes it easier to trust the person you lend to, but they have to be repaid. And I think there's one thing that is a kind of an unspoken, I don't want to call it the dirty secret, but it's an unspoken part of this, which is that in many cases, if you're talking about using a debt or a bond or loans or whatever for the developing world, the slow developing world, the Nigers and I mean, okay, Ethiopia's a little bit further, but you know, that if you're using it, then you're expecting in some cases, them to repay it. And, you know, there's so the unspoken deal is, we will lend you money, you get wealthy, you improve your social performance, economic performance, and then it won't be difficult to pay this back. You know, and Rwanda, I did a piece of work on Rwanda in 2013, where the government was saying we can provide 50% electrification by 2025. And I did the numbers and said, frankly, that's just not good enough. You know, you could do 100% electrification using these distributed technologies at the same price. What you need is, you know, $5 billion to go and do it. And then, and the deal has to be, then you get so wealthy, your ability to, your tax envelope grows and you can pay it back. Or you have to find people in the West who are prepared to just put that money in. And so there's a little bit of, you know, I think you can put that capital stack together, and there is some of it. What needs to happen though is some of it has to come from the host nation, because I think we all know that the model that says it all comes from donors says that it probably all ends up in Switzerland, or it goes to the country, but then the solar doesn't work because nobody's invested in it. So you've got to take the capital stack has to start with even the 2 hours, Laura, I'm pointing at you on my screen. Laura, even even the 2 hours that you talked about, that is money. That has to be put into the stack, because that's the table stakes from the host. Because then you can get donors to say, well, if Mali can put in the equivalent of 2 hours a day of funding, and that's all they've got, then will you put in through donors, through governments, etc., and guarantee it for a period enough to get that enough to do the proper electrical, solution, the engineering solution, and the maintenance and the things that have to go with it.
24 hours.
But I do think we need to understand that just expecting the country, if you just say to the ministry, well, you guarantee it, you are also sucking money out of that economy. And it has to then, and the problem with healthcare is, of course, that you save a baby's life or a mother's life. There's no obvious cash flow until that person becomes a productive, a productive member of the economy with a job that's generating tax revenue and so on. So there's these huge gaps of, for that individual. As a country, having people healthy and not dying in childbirth and those that. But we're in that zone. That's right. Maybe it comes back, I'm rambling here, but maybe it comes back to telling that story with a little bit more honesty, frankly. Because when you talk about bonds and debt, they just sound like free money to a lot of people in the development world. And they're not. They have to be repaid, and there is a drag thereafter from whoever's paying them. You're muted. Laura, you're muted.
Got it. I just want to add another payer that I think no one's really thinking about. You were talking about these sort of small payers. Well, what we've done, and I've done research on 1,200 health workers trying to understand what life is like in 11 countries over 10 years. Some of the payers are the patients themselves. They're asked to bring candles with them, or payments for kerosene, or money for the batteries, or then the health workers themselves have to decide, are they going to pay for these things? So there isn't a line item in the ministry or district health budget, because these things are being basically covered by the actual beneficiary and users. And in a lot of cases, families that are quite poor will literally stay at home because they don't even have the money, or they don't want to bring the 6 candles, which in Zimbabwe, if you're a patient going to deliver in a health center, you're expected to pay for 6 candles and bring them with you when you go into labor, or you will not have
we looked in, Laura, has anybody, or David or anybody, Jem, you would know, has anybody looked at bundling remittances to pay for this, but not as a kind of one-off, oh my goodness, we've got, I'm a Ghanaian, I'm in hospital, but my cousin is in London working security on a transport for London, whatever. And instead of going and asking for, $500, has anybody looked at trying to bundle these into, $1 a month or things? Because the technology enables so many more structured products. Somebody has to put them together. Actually, where's William Brent when you need him,
Yeah.
I mean, we have not looked at remittances, but we have looked at, for example, at corporate kind of sponsorships, or leveraging domestic corporate capital, either in a CSR or some sort of kind of sponsorship model. We actually looked at that in Uganda. And I think, these avenues need to be looked at. I think what I would,
but remittances are so obvious in a way. If there was an easy way to get somebody's relative in US, in Europe, and wherever, to just and not to break their budget, because going to do you see what I'm saying? That if you go to them and you say we need $500, then nobody has $500 sitting around. But if you say, look, this is what we need, and it's $1 a month, for 5 years or whatever, that's so much easier. If the technology just made it, I just click here and it's $1 a month. Hell,
I mean, can I just jump in by way of comparison of somewhere? If you visit a health clinic, in a random health clinic in rural, remote part of an African country, there's actually a pretty high likelihood that there is one piece of equipment that is powered pretty reliably, and that's the vaccine refrigerator. And it's not a coincidence. There's a huge investment, both public, both kind of government as well as donor, in creating cold chains because of what I think Michael or someone's earlier comment, the math, the business case for making sure that we have vaccines available and effective at the last mile is known, it's documented, and it's understood. And so it is no surprise that this huge cold chain and investment in cold chain has been created with the help of the Gates Foundation, et cetera. The problem is we've only done that with one health service, vaccines. We need to broaden that out. And that's where I think there's an opportunity to work with the likes of Gavi and others. There's a little bit of a mindset shift, kind of a mindset shift that has to occur, because the Gateses of the world think about healthcare in terms of specific diseases, not in terms of broad-based health system strengthening. But the model is there. We actually see, I mean, cold chains, generally speaking, at least compared to the maternity ward or the health, the staff quarters, is working relatively well. So
let me play my role on Gavi, Global Alliance for Vaccines, which has done a great job in terms of increasing access to vaccines by putting in multi-country financing and a whole bunch of mechanisms that have really changed the game in vaccines. So there's a model there in that regard.
So I was going to ask Jim that you seem to think that this kind of the single piece of equipment solution is in some way undesirable, but on the other hand, you're also saying that it really works. And you know, I put a link into Ignite Solar. Okay, so they have Ignite Medical Services. What they've got is these designed for solar ultrasound, designed for solar X-ray, designed for solar blood diagnosis. And it's not just that you've got the local machine, you've also got internet access, which means that results can then, you know, you can then tap into the global knowledge base. And I don't know, you know, obviously it's better if you have a whole clinic with a full range of lighting but I just, you know, maybe, particularly I'm thinking also around COVID, you know, you have got people right now prepared to spend money on blood analysis, on diagnostics. And maybe that's, you know, maybe that's the Trojan horse approach, that you say, well, let's get, you know, 3, 4, 5 different vaccine refrigerators. And then you've got a stream of cash flow. So then you can say, well, wouldn't it be cheaper if we just, you know, put this all into one, you know, you can then justify upgrading a system and linking them and so on.
Yeah, I mean, Michael, I think that's a good point. I think what I was referring to with vaccines is we've done our homework and we know the math. We know what the payoff is. We know how cost effective it is, either in human lives or economic terms, in making sure that that vaccine is effective at the last mile. And so it's no coincidence that there is probably, in many cases, a solar powered vaccine refrigerator in that health clinic. I think I think in an ideal world, we want to move away from this kind of single solution, service by service approach, because then you create this kind of this monstrosity at a health facility where there could be 4 or 5 systems that could be installed by different people, different manufacturers, different specs, etc. So I think there's an, you know, I liked your earlier reference to a systems-based approach. We need to be thinking about health clinics from a systems point of view, and I would make the argument we have to think about the health clinic in the context of the broader system, which is the community, because in many cases a mini grid might be a viable solution. So, well, I think there are instances and places where to just kind of, we need to get something done. Let's power a particular service or two. I think as a sector, we need a vision as to where we're headed, and I think that.
I agree completely. So the way to resolve this is not to have 6 completely different systems, but it's to make sure that there is a kind of a stamp or a kite mark or a standard that says this piece of equipment is appropriate because it's been designed to fit, to play nicely with all the other things that might turn up in this clinic in the future. Because you're not going to get 0 to 100 mile an hour solution. It's going to be added, needs to be modular. But what does modular look like? How do you grow a system? And in fact, Laura, you showed, you know, local to, you know, to regional to hospital. And then, but there's another one, which is that hospital might get a refrigerator and some lighting, but then it might get some ultrasound, and in 3 years it might get an X-ray machine. So how do you make sure that that hospital is forward compatible? What do we need to do?
I also just want to add one thing and then call on someone else who's been waiting patiently from UNDP. What I want to add is, if we develop the technologies you're talking about, Michael, they will have a huge market back in the industrialized world. Because every time we've done these types of things where we've worked on highly efficient devices, we find that they are actually very useful at a time when all of us should be heading towards greater energy efficiency. I'd like to ask Glenn from UNDP. You've been incredibly patient. Please share.
Wait, Glenn, and then Ayotunde, and then Yangbo. You can have the last word actually, and then we'll let everybody go and follow up in due course. So Glenn.
Thanks so much. Yes, I also need to leave quite soon, so I wanted to first thank everybody very much for the conversation and the dialogue. It's been very enriching. So many different ideas and a really valuable team of people gathered. So first I would say, you know, let's please have more of these dialogues. I think they're very helpful, and some of the different relationships that could be built here by people like us who are working, you know, to develop projects on the ground would be super helpful. Then I also wanted to just say, also I had some colleagues on the call today from both the energy, you know, working on the energy side and on the financing side. We're looking at developing a truly holistic and integrated program in Rwanda for health system strengthening at the primary care level that will involve integration of solar solutions into a kind of integrated and holistic approach. And I think kind of what I wanted to say was from the discussion was, I appreciated, I think, Laura and others' interventions of kind of like a let's get real, you know, come to Jesus moment, like the level of sophistication at this level, the level of equipment, the level of ability for end users to pay is, you know, very low. It's there, but you know, we're not talking about the same kind of projects that where, you know, even if you have a lot of scale, you're not talking about the same kind of larger infrastructure or financing kinds of projects. So I think we have to be clear when we talk about financing solutions, you know, that there are these there's a different reality at that level, particularly when we're talking about sub-Saharan Africa and probably other like least developed countries and small island developing states. And then the second point is, you know, this is not all pure public investment either. What we're trying to work on here is partnership models where you have social enterprises working in the health space, as well as energy companies, solar energy companies that are also trying to develop their market for services. So there is some degree of private investment, and I liked what the Health Financing Institute was saying around, you know, what's really at stake is finding the appropriate blended financing solutions. We're not quite sure what that is, and that's something we're investigating over the current time in Rwanda, what makes sense. We don't see it as a purely public or private solution, but figuring out the right solution for this specific challenge and this specific context here, and doing that assessment in terms of, you know, what can we build on, you know, in terms of existing funding, existing renewable energy risk mitigation schemes, and health financing, you know, support. And the government has tried various things before to be innovative in terms of public health financing, but I think what we're trying to do is push the envelope even further with support of the Ministry of Finance and the Ministry of Health to come up with a realistic partnership. So anyway, just to say thanks so much, and we look forward to further input and discussions from everybody as we try to find the right solution here. Thank you.
Thank you. Ayotunde is somebody we know worked on healthcare in the banking sector in Nigeria. Ayotunde.
Hello, everyone. How are you today?
Good,
right. So from the banking side, so I'll go a little bit back about some context of Nigeria now. When financing healthcare and trying to partner, especially at the primary healthcare level, at the tertiary level, a challenge has been the government not providing enough funding to run those centers. So they don't work, they don't have electricity, they don't have staffing, they don't have all of these things. Now, what we have worked on in collaboration with the Farm Access Foundation and a couple of states is a solution where the government concedes these primary healthcare centers to private operators, and we in the banking sector come in to provide financing to the private operator to take on that center. They renovate, they manage, they operate, they provide the infrastructure. Now, the challenge has been, in Nigeria, again, there isn't, only 5% of the population has health insurance. So the challenge remains, how will people pay for the services that you render? So we need to begin to find solutions to address that effective demand. And so partnerships with the UNDP, the UBS Foundation on the demand side to strengthen that part while you have somebody developing the supply side, which is the private operator providing those facilities and doing that. Because again, even if in primary healthcare centers across most of sub-Saharan, even if you provide power, the staffing is still not there. The consumables are not there. All of those other things that you need to be able to provide quality and affordable healthcare are not there. So you need a whole solution that addresses all those things. Power is important, is key, but you need to address the supply side, you need to address the demand side, you need to address the supply chain. And so you need a robust partnership that brings together all of these things. And so those are some of the things we've looked at. Yeah, we've done some financing, we've done that. But again, because of the high interest environment, because of the effective demand, those solutions are not necessarily affordable and it's difficult to scale. So whilst you have a few successes here and there, scale is difficult to achieve scale because you don't have a solution that covers effective demand, that covers the demand side, that covers the supply side. And so that is something that we need to look at. And this room is great because there are people financing, there's UNDP who are structuring solutions. There's so much that we can do. And there's state governments around the country who are willing to partner, who are willing to consider the centers as long as they don't care about the dynamics of it. They just want to provide quality and affordable healthcare to their citizens. And so we come in with a whole bucket, this whole solution that allows them to do that would be great. So yeah, thank you for having me.
Great. Youngbo, you're a regular, and I know you think systemically. So have at it.
Well, quite apt since where much of this conversation was aiming at was in fact covered this morning, much earlier, since I'm running on Central European time there, from the ICLE Daring Cities symposium, and they covered what could local governments do in terms of facilitating climate smart finance. So to Michael's point about breaking down silos, knocking heads together, there really isn't any better type of organization than a local government that's in a position to do that. For instance, especially with power utilities, that instead of, they're in a very good position to consider what would be an energy-enabled service delivered, as opposed to if you were an independent power producer, it might still be how many gigawatts installed and that, so they could move from that, and also far more nimble. In many cases, if given enough fiscal space, own source revenue to maneuver, than many national governments. That's one. And secondly, on this business model side, and share a couple of links to that end, and haven't really seen this covered all that much. For those of you who are also involved in public transport and land use planning, you're probably more familiar with it. Brought the example of Japan earlier, that if electrification, especially microgrids, if that could be coupled with improvements in the quantity and the quality of building stock in a municipality. So for instance, that because of lack of electricity, often you can't build more than 2 or 3 stories, so you're having a lot of issues with overcrowding in many settlements. If you're then able to go higher, not only that, but you could use that additional value add you captured, especially if the local government's implementing it, capture that value added, use that to cover the capital costs, operating costs, especially for renewables, next to nothing compared to fossil fuels, so that you could even sell that renewable power at operating cost to the end user, who at least pay. And then lastly, just probably the biggest proverbial elephant in the room here, and given the financing question is when mention of fossil fuels, is it's probably changed now, but still, unfortunately, still too high. It was well acknowledged over 5 years ago during the SE for All Symposium series at the United Nations that over $500 billion a year of fossil fuel subsidies are being spent in less developed countries. So really, before we even get to this talk about, well, philanthropic investing, donations, such, it's honestly, it's borderline farcical to talk about that without addressing this $500 billion to $5 trillion question of fossil fuel subsidies. So leave it at that, figure out how to redirect those flows of funds from fossil fuels to renewables. And that could be a whole nother topic for a future call.
Terrific, thank you. And thank you all. You can see this is a very rich topic. There's plenty more to say and do. I hope that you did meet some folks that you didn't know before, and that maybe there's some partnerships and collaboration that comes out of this. We at ImpactAlpha will stay on top of it. I know We Care Solar will as well, but thank you, Jem. Thank you, Rehan. I think Phyllis may have dropped off, and Michael, and all of you who come. Laura, do you want to just send us on our way? You have to unmute though.
Thank you, David, for hosting. This was the 4th of our 10-year anniversary 10 by 10 webinar series. So if any of you would like to learn more about the activities that We Care Solar is doing, please go to our website, which I put up earlier and can share again. And I invite you to come.
WeCareSolar.org.
Yeah, and we'll be having ones on how to scale up leadership, the education programs, because we have programs in schools as well. So you're welcome to do those. And David, you did a masterful job. Thank you. And thanks to all of the panelists. You were brilliant. And we've dreamed, David and I have dreamed for a long time about having this exact conversation, and it was actually better than expected. Thank you so much for everything you are doing in your own work for this, and for joining us together to really try and elevate the conversation and come up with solutions.
And the 35 of you who are still here, give yourself a big round of applause, because you're the hardcore. So thanks for everything, everybody.
Thank you. Thank you.
Thanks, Laura. Thanks, David, for organizing.
Thanks, David.
Great conversation.